Welcome to the official GlobalRPh YouTube channel. We're thrilled to have you here. If you haven't already, be sure to hit that subscribe button so you never miss out on our latest videos. Our dedicated production team is hard at work creating engaging and informative content that caters to a wide audience. 1/3 of patients who develop heart failure face a hidden challenge: iron deficiency. Research shows that about 34% of newly diagnosed heart failure patients have iron deficiency. This condition persists at 32% even after a year. Iron deficiency's effect on heart failure patients goes well beyond the original diagnosis. The first year after diagnosis reveals an interesting pattern. 19% of patients continue to have iron deficiency, 13% develop it as a new condition, and 11% see their condition improve. Several factors substantially raise the risk of iron deficiency. Anemia at the start of treatment stands out as the strongest risk factor, while heart failure hospitalization and being female also play important roles. A detailed study of 547 patients from 5 major Stockholm hospitals revealed these findings. They showed how iron deficiency affects heart failure outcomes. Patients' quality of life takes a measurable hit, as shown by a 7.4-point difference in the Minnesota Living with Heart Failure questionnaire score at the beginning of treatment. These results highlight why healthcare providers need to understand, detect early, and properly manage iron deficiency in heart failure patients. Understanding iron deficiency in heart failure. Iron deficiency shows up in 2 different ways in heart failure patients. Each type has its own features and affects patient care differently. Defining absolute versus functional iron deficiency. Iron deficiency in heart failure presents as either absolute or functional depletion. Absolute iron deficiency reflects depleted iron stores, often resulting from blood loss, poor dietary iron intake, or malabsorption. Consequently, functional iron deficiency occurs when total body iron remains normal or increased, yet becomes inadequate for tissue needs due to iron sequestration. The diagnostic criteria for iron deficiency in heart failure includes ferritin level less than 100 micrograms per liter indicating absolute deficiency, ferritin between 100 to 300 micrograms per liter with transfer and saturation less than 20% suggesting functional deficiency. Prevalence across different heart failure phenotypes. Iron deficiency affects many heart failure patients, and its rates vary by clinical situation. About 50% of patients with stable heart failure don't have enough iron. The numbers go up in acute decompensated heart failure, where up to 80% of patients have this problem. You don't need to be anemic to have iron deficiency. More than 40% of heart failure patients who aren't anemic still have low iron stores. Research shows that low iron levels affect heart failure progression more than anemia by itself. Key pathophysiological mechanisms. Iron deficiency in heart failure happens through several pathways. The body absorbs iron through enterocytes in the duodenum and upper jejunum. A hormone called hepcidin controls iron absorption and how cells export iron through ferroportin, which is the only protein in mammals that can export iron. Heart failure patients face several challenges with iron regulation. Intestinal swelling affects absorption. Not enough iron in their diet. Multiple medications interfering with each other. Ongoing inflammation. Heart muscle cells need lots of iron because they use so much energy. This shortage of iron doesn't just affect the heart. It also impacts how skeletal muscles work by changing their energy metabolism and how they process carbohydrates and fats. New research shows that heart failure patients have lower levels of proteins DMT1, TFR1, and LCH, which makes it harder to transport iron. Low levels of ferritin proteins, especially FTH, are linked to higher risk of heart failure. Early detection of iron deficiency plays an important role in managing heart failure effectively. Research shows that iron deficiency affects up to 50% of heart failure patients who can walk around. This makes early detection a top priority in patient care. Heart failure patients who lack iron often deal with multiple symptoms that impact their daily life. These patients experience less exercise capacity and reduced physical well-being. The symptoms that show up include fatigue and shortness of breath, rapid heartbeat while resting, headaches and dizziness, pale, dry skin, and restless leg syndrome. Research shows several factors that increase the chances of developing iron deficiency in heart failure. Women have a higher risk, along with patients in advanced heart failure stages. Patients with high levels of N-terminal pro-B-type natriuretic peptide, or NT-proBNP, and C-reactive protein are more susceptible. The mechanisms come from multiple sources. Poor diet and reduced absorption from gastrointestinal tract congestion lead to iron deficiency. Blood loss, which often happens with antiplatelet and anticoagulant medications, adds to the risk. The European Society of Cardiology guidelines highlight detailed screening protocols. Current guidelines require regular iron deficiency checks for all heart failure patients, unlike previous recommendations that only focused on new cases. Doctors measure two key factors during screening: serum ferritin and transferrin saturation, or TSAT. Iron deficiency gets diagnosed under two conditions: serum ferritin below 100 micrograms per liter, and serum ferritin between 100 to 299 micrograms per liter, with TSAT below 20%. Regular monitoring matters because research suggests checking iron status 1 to 2 times each year. Doctors should check iron levels after a patient leaves the hospital for heart failure. Healthcare providers can spot at-risk patients early through proper screening and detection, before complications develop. Iron deficiency affects heart failure progression at the cellular level through multiple pathways. The molecular changes show how iron deficiency hurts oxidative phosphorylation and reduces intracellular content of phosphocreatinine and ATP. These changes hit tissues with high energy needs hardest, especially the myocardium and skeletal muscles. Iron deficiency changes cardiac performance in several ways. Studies show that iron-depleted cardiomyocytes have lower ATP-linked respiration and a weaker respiratory reserve. This energy crisis results in poor myocyte shortening and slower relaxation kinetics. The heart tries to compensate, but iron deficiency reduces cardiac output. This limits the heart's ability to pump harder during exercise. Research shows that heart failure patients with iron deficiency have lower left ventricular function, reduced cardiac output during physical activity, poor force-frequency relationship, and damaged mitochondrial function. Heart failure outcomes are closely tied to how severe the iron deficiency is. Studies show iron deficiency affects 50% of outpatients and up to 80% of acute heart failure patients. The numbers tell us that iron deficiency by itself predicts worse functional capacity and lower survival rates. Patients with iron deficiency start to show signs of decompensated cardiac state when hemoglobin levels drop to about 7. The effects go beyond anemia, as iron deficiency alone changes oxidative metabolism and oxygen availability for myocardiocytes. Iron deficiency has a marked effect on patients' daily life and well-being. Clinical studies show that heart failure patients who lack iron have much lower exercise capacity and quality of life. Exercise tolerance takes a big hit. Patients with iron deficiency show lower peak oxygen consumption compared to those without it. The good news is that fixing iron deficiency through intravenous iron therapy helps improve quality of life and exercise performance, whatever the hemoglobin levels. Clinical trials back up these findings. The FAIR-HF study with 459 outpatients showed big improvements in New York Heart Association class, walking test performance, and quality of life after iron supplementation. These improvements happened whether patients had anemia or not, which shows iron's crucial role in cardiac function and patient well-being. Doctors face unique challenges when diagnosing iron deficiency in heart failure patients due to the complex relationship between iron metabolism and cardiac function. Bone marrow iron staining remains the gold standard for diagnosis, yet its invasive nature makes it impractical for regular clinical use. The European Society of Cardiology has established guidelines that define iron deficiency using two key measurements: serum ferritin and transferrin saturation, or TSAT. These are the original conditions for diagnosing iron deficiency: absolute deficiency, which is serum ferritin below 100 micrograms per liter, and functional deficiency, which is ferritin 100 to 299 micrograms per liter with TSAT below 20%. Recent studies have questioned how accurate this definition really is. Research shows that patients with low ferritin but normal TSAT, greater than 20%, usually don't have bone marrow iron depletion. About 26% of patients who have ferritin levels above 300 micrograms per liter show TSAT below 20%. New biomarkers could improve diagnostic accuracy significantly. Soluble transferrin receptor, or STFR, levels strongly relate to bone marrow iron depletion. STFR gives more reliable results because inflammation doesn't affect it. Serum hepcidin offers another promising diagnostic tool. This peptide comes from hepatocytes and controls iron uptake and release. Studies show that hepcidin might track iron stores more accurately than traditional markers. Traditional diagnostic methods have several major challenges. Serum ferritin isn't reliable in heart failure patients for these reasons. Inflammation artificially raises ferritin levels. Cell damage releases ferritin even during iron deficiency. And some medications like neprilysin and sodium glucose cotransporter 2 inhibitors might affect ferritin levels. TSAT measurements are more reliable than ferritin alone but have their limitations. TSAT changes throughout the day. Advanced renal insufficiency or malnutrition can falsely lift TSAT values. New evidence suggests that combining serum iron levels less than or equal to 13 micromoles per liter with TSAT less than or equal to 19.8% identifies true iron deficiency more accurately. These measurements show 94% sensitivity and 84 to 88% specificity compared to bone marrow examination. Diagnosis becomes even trickier in acute heart failure cases where traditional markers are nowhere near as reliable. Research continues to explore new diagnostic approaches. The biggest problem remains standardizing these newer testing methods. Treatment strategies and guidelines. Modern treatment guidelines put intravenous iron at the forefront to treat iron deficiency in heart failure patients. Clinical trials show that this therapy helps patients feel better and spend less time in hospitals. Intravenous iron therapy protocols. The European Society of Cardiology guidelines strongly back intravenous iron treatment. They give it a Class 1 recommendation when heart failure patients with left ventricular ejection fraction below 45% show symptoms. 2 main formulations lead the way in clinical practice: ferric carboxymaltose and ferric dirosomaltose. The protocol for ferric carboxymaltose follows these steps. You can get up to 1,000 milligrams per week as your first dose. Your iron levels determine maintenance doses. The treatment takes 30 minutes through a low-volume infusion. Research backs this method well. 4 randomized trials show that intravenous ferric carboxymaltose helps heart failure patients move better and feel better. The FAIR-HF trial showed better quality of life scores. CONFIRM-HF proved the benefits lasted 52 weeks. EFFECT-HF revealed patients could use oxygen more effectively. Oral supplementation considerations. Heart failure patients don't respond well to oral iron supplements. The Iron Out HF study found that even high-dose oral iron didn't help patients exercise better or feel better. Here's why it doesn't work. High-dose oral iron polysaccharide barely changes iron stores, even though it provides 20 times the daily recommended amount. The body fights absorption because swelling in gut walls blocks absorption. High hepcidin levels stop iron uptake. 40% of patients get stomach problems. Treatment response monitoring. Doctors need to watch iron levels carefully after treatment. They wait 2 to 3 weeks after giving intravenous iron to check levels because readings are artificially high right after treatment. The monitoring schedule looks like this. Doctors check iron status at 3 and 6 months after treatment. Low iron levels mean you need more doses. Patients with normal iron levels need yearly checks. European guidelines tell doctors to screen all heart failure patients regularly. This helps catch low iron early, especially in patients with gut or urinary tract problems. Regular monitoring continues until iron stores return to normal, which helps patients get the best results. Special population considerations: elderly patients. Age affects iron deficiency patterns in heart failure patients considerably. Studies reveal that heart failure patients with anemia tend to be older. The numbers exceed 20% in people aged 85 years and above. These patients often show lower blood pressure, greater edema, higher diuretic needs, higher neurohormonal activation. Elderly heart failure patients usually have preserved ejection fraction. They also show higher rates of hypertension and atrial fibrillation. These patients need careful monitoring because they often don't respond well to standard treatments. Chronic kidney disease. Heart failure combined with chronic kidney disease creates a complex condition called cardiorenal anemia syndrome. Doctors face unique challenges in diagnosis because uremia and inflammation affect traditional iron markers. CKD patients with heart failure show distinct patterns. Iron deficiency diagnosis in CKD patients uses different parameters. Absolute deficiency, ferritin less than 100 nanograms per milliliter in non-dialysis CKD patients. Functional deficiency, ferritin less than 200 nanograms per milliliter in dialysis, dependent patients with TSAT less than 20%. Prevention and management strategies. Medical interventions alone don't work for managing iron deficiency. Research shows that patients with heart failure need a complete approach that combines regular monitoring with changes in diet. Dietary interventions. Iron-rich foods are the lifeblood of preventing iron deficiency. Heart failure patients should eat red meat and poultry, selecting lean cuts, fish and shellfish, dark green leafy vegetables, iron-fortified cereals and breads, legumes and peas. Foods rich in vitamin C help your body absorb more iron from dietary sources. You should eat vitamin C-rich foods with your iron-containing meals. Some substances block iron absorption, so take coffee, tea, or calcium supplements at least 2 hours away from iron-rich meals. Lifestyle modifications. Your daily weight is an important indicator of heart failure status. The best time to weigh yourself is each morning, before breakfast, and after using the bathroom, while wearing similar clothes. Call your doctor if you gain 2 to 3 pounds over several days or 5 pounds in a week. Blood pressure needs careful tracking too. Home monitoring and regular clinical checkups help keep your blood pressure under control. These measurements give us the full picture and rule out false readings when properly recorded. Regular monitoring protocols. The European Society of Cardiology guidelines require systematic screening for iron deficiency in all heart failure patients. The monitoring protocol includes: doctors should check iron status during diagnosis and follow-up visits. They need to look at serum ferritin and transferrin saturation levels. After starting iron replacement therapy, monitoring happens at specific times. We check again after 2 to 4 weeks for moderate to severe anemia. Hemoglobin should rise by 10 to 20 grams per liter international units within 4 weeks. Iron levels get rechecked after 3 months. Monitoring continues for 4 to 6 months after anemia improves. Patients getting intravenous iron therapy need observation for side effects for at least 30 minutes after treatment. The target ferritin levels should be higher than 100 micrograms per liter. Doctors must look for ongoing bleeding, malabsorption, or other conditions if ferritin and hemoglobin don't respond as predicted. Regular screening becomes especially important for patients with gastrointestinal conditions or those taking antiplatelet medications. Healthcare providers can spot and fix iron deficiency early through consistent monitoring and proper dietary changes. This approach helps prevent complications and leads to better outcomes for heart failure patients. Future directions and research. Scientists keep pushing forward with new clinical trials and fresh approaches to manage iron deficiency in heart failure patients. Their latest studies are reshaping the scene of treatment and diagnosis in this field. Novel therapeutic approaches. New treatment strategies for iron deficiency and heart failure are under the microscope in clinical trials. The HEART-FID trial breaks down how ferric carboxymaltose affects a combined outcome that includes death rates, hospital stays, and walking distance tests. The study's results showed important long-term safety data about repeated ferric carboxymaltose infusions. Scientists are working on different treatment protocols. FAIR-HF2 and Ironman trials want to shed light on intravenous ferric carboxymaltose's role. Teams now test combinations of quick intravenous iron treatments with long-term oral maintenance therapy. Research teams get into iron sucrose as another option to ferric carboxymaltose. The FAIR-HF2 trial looks at how intravenous iron changes skeletal muscle energetics. Other research teams review its effects on mitochondrial gene expression and heart muscle iron levels. Emerging diagnostic tools. New diagnostic methods could replace traditional testing approaches. T2** cardiac magnetic resonance imaging might help detect heart muscle iron deficiency. A compact study showed significant iron buildup in heart muscle after ferric carboxymaltose treatment, which matched improvements in function. Scientists found that transferrin saturation, TSAT, could work better than older markers. TSAT levels at or below 19.8% help identify patients who have fewer heart-related hospital stays and deaths. This discovery challenges old diagnostic rules and points to simpler but more accurate testing methods. questions linger about how iron metabolism works in heart failure. The PREFER-HF trial reviews both oral and intravenous iron's effects on symptoms and function. The FAIR-HF-PF study looks at how intravenous iron changes exercise tolerance when ejection fraction stays preserved. Scientists must find out how iron therapy works with common medications. Age, other health conditions, and medicines like beta blockers and SGLT2 inhibitors can throw off traditional iron deficiency markers. Teams also need to create better screening methods to find underlying causes of isolated iron deficiency. Safety remains a top priority. The Heart-FID trial noted 5 cases of hypersensitivity and 2 cases of angioedema with ferric carboxymaltose. Research teams must run longer studies to confirm that repeated doses work safely beyond 1 year. Latest research explains that many heart failure patients have enough total body iron but can't release it properly. This finding points to the need for studying how cells access iron. The ratio of soluble transferrin receptor to TSAT might help future studies show specific patterns of iron loss in muscle cells. Conclusion. Iron deficiency stands as a critical yet manageable risk factor affecting heart failure patients. Research demonstrates that approximately 1/3 of newly diagnosed heart failure patients face this challenge, significantly impacting their survival rates and quality of life. Medical evidence supports systematic screening and early intervention through intravenous iron therapy. Studies show marked improvements in patient outcomes, exercise capacity, and daily functioning when healthcare providers address iron deficiency promptly. Though diagnostic challenges persist, emerging biomarkers and innovative testing methods offer promising solutions for accurate detection. Special populations, particularly elderly patients and those with chronic kidney disease, require careful consideration and tailored treatment approaches. These patient groups benefit from regular monitoring and adjusted protocols based on their specific needs. Clinical trials continue to explore novel therapeutic approaches and diagnostic tools. The Heart-FID, FAIR-HF2, and Ironman trials aim to establish long-term safety data and optimal treatment protocols. Cardiac magnetic resonance imaging and refined diagnostic criteria show potential for improving iron deficiency detection accuracy. Healthcare providers must remain vigilant about iron status monitoring while adapting treatment strategies based on individual patient factors. Through comprehensive management approaches combining medical interventions, dietary modifications, and lifestyle changes, patients with heart failure can achieve better outcomes despite iron deficiency challenges. Frequently asked questions. How does iron deficiency impact heart failure patients? Iron deficiency significantly affects heart failure patients by impairing cardiac function, reducing exercise capacity, and lowering quality of life. It can lead to decreased left ventricular function, reduced cardiac output during physical activity, and compromised mitochondrial function. What are the warning signs of iron deficiency in heart failure? Common symptoms include fatigue, shortness of breath, fast heartbeat during rest, headaches, dizziness, pale skin, and restless leg syndrome. These symptoms often affect daily activities and physical well-being. How is iron deficiency diagnosed in heart failure patients? Diagnosis typically involves measuring serum ferritin and transferrin saturation, TSAT levels. Iron deficiency is indicated by serum ferritin below 100 micrograms per liter or between 100 to 299 micrograms per liter with TSAT below 20%. However, emerging biomarkers and imaging techniques are being explored for more accurate diagnosis. What is the recommended treatment for iron deficiency in heart failure? Intravenous iron therapy, particularly using ferric carboxymaltose, is the primary recommended treatment. It has shown significant improvements in symptoms, functional capacity, and quality of life for heart failure patients with iron deficiency. How often should iron levels be monitored in heart failure patients? Regular monitoring is crucial. Iron status should be evaluated at diagnosis and during follow-up visits. After initiating iron replacement therapy, levels should be rechecked after 3 months. Annual monitoring is recommended for patients with normalized iron stores. Thank you for watching our GlobalRPh production. If you found it enjoyable and informative, please consider liking the video and subscribing to our brand new YouTube channel. Your support helps us grow and continue to provide interesting and valuable content. Stay tuned for more exciting videos.